Good afternoon again, everybody, and I am delighted to welcome you to the first discussion panel of day 2 of Your Show 2025. Don't forget that link, yourshow.uk/donate, if you can support what we're doing. We're going to be talking about the NHS today, and people who know me from Skwawkbox may not know that it originally started off as a specific NHS news site before moving on to wider politics, including the NHS. But I'm delighted to have two people, one in the studio and one online with me today, who know a lot more about it than I do. We have Rathi Guhadasan, who is a former NHS paediatrician who has spent over a decade in global child health, and is currently the chair of the Socialist Health Association. And coming in online, we have the fantastic Csergo, who is somebody I've known for a long time and is one of the people, when I'm writing about the NHS, who is a go-to source for me to double-check that I'm making sense and to find out the facts that I may have missed. So I'm delighted to welcome you both. I can see Nico now. That's good. So we're going to be talking about the current state of the NHS. The theme of today is the NHS. Is it too late to save it? We'll talk about how it's perceived by the public, hopefully how it's seen by those who are working in it as well, and the realities for people who are trying to get treated by what used to be one of the world's greatest treasures and certainly Britain's greatest achievements. So how do we get to where we are at the moment? Rathi, do you want to go first on that?
So the way we find the NHS that we see today didn't start with this government or even the last government. It started back in the 80s under the Thatcherite government and the introduction of the internal market into the NHS. And then those policies were compounded during the New Labour Blair era, and we had the massive expansion of PFI into the NHS. We're still paying for that. We've actually paid off most of the capital amount that was originally invested, but we're still paying for that, and we will continue to pay for that unless that debt is dealt with. And then, of course, when the Conservative Liberal Democrat coalition came in, then we had the successive Health and Social Care Acts of 2012 and then 2022 that really kind of made it very explicit. I mean, no one can say that we didn't know anymore. It went through Parliament with a large amount of publicity and essentially ended the era of the NHS as Bevan had originally envisaged it, and it entered the era of commissioning for services. And
because the 2012 Act removed the Health Secretary's responsibility to provide NHS.
Yes, for every single person in the country, in the population. So, I mean, that is it in a nutshell. And the private sector, driven from the huge corporations from the US, has taken, every advantage of this, as you imagine they would. And unfortunately, the Labour government coming in now, if the policies continue in the current direction, is only going to accelerate these different ways in which the resources of the NHS are actually being leached out to the private sector all of the time, and actually outcomes are getting poorer for patients. So that in this debate, the thing we don't talk about sometimes enough is what's happened to people in the meantime. And what we can see is this was obviously compounded in the last decade and a half with austerity as well, and we're obviously now entering austerity 2.0. So in that time, we've also seen life expectancy falling for the poorest. We've seen maternal mortality rising. You mentioned that I used to work overseas. I used to work with very, very, very poor communities, where childbirth is an incredibly dangerous thing for mothers and for babies. But things are moving in the right direction despite enormous challenges in very low resource settings. And I come here back to the UK and find that maternal mortality is rising, and it's really unacceptable in the 6th richest country in the world. Child health is declining across a range of parameters and so on. So this population health decline is happening in parallel with the continued fragmentation of the NHS as different private sector entities compete for different aspects of the profitable parts.
Yes.
So that's what I would say in a nutshell. But Nico has a huge amount of experience on this. So yeah, it'd be.
Yes, I want to come to you, Nico, because Rathi has talked about the Tories and the Lib Dems and the current NHS government, the current Labour government, excuse me, goes by that name at least. But I know from previous conversations that we've had that your understanding of this is that this is not the first Labour government to be involved in the attack on the NHS. So why don't you give us your knowledge about how that's all developed and where it all started?
Sure, and I'm to be fair, Rathi just did mention that New Labour continued what the Tories had done before. I think that there's a big gap. I'll just start at the wrong end, but there's a big gap, I think, in left discourse in terms of looking at what Labour's position was between New Labour's closures, cuts, and privatisation, and the current Labour government. Where was Labour in the meantime? Because that's a big issue. That's where I've been focused, and that. What I've seen from inside the party, from working with researchers, from looking closely at what Labour's actual position is through the rhetoric, is that they hadn't changed position between the first Milburn government to the current Milburn government, if you like, Alan Milburn being in part of the current government. So the Department of Health and Social Care. So I think that's a big issue, and I think it's also a big issue for the conversations that we're having about alternatives to Labour is that we need to be talking about that. The Labour has not been on the side of the NHS for a very long time. Now, in terms of the overall story, I also think there's a real weakness or problem with the need for a story that tells in a graspable way for the public, for public discourse from the left. And I think I would read the title of this discussion, is it too late to save the NHS, in terms of is the left too far gone to be able to actually do anything about it? That's what I think. It's a political challenge, and it's not because this or that has been done to the service, although there are huge challenges when you close hospitals and replace them with luxury flats that are in central areas. How do you bring those back? There are challenges like that, but the main challenge is whether the left is going to collectively, in terms of the alternatives that are coming up, provide what Labour provided in 1945. Would people have said the current Labour Party wouldn't have brought in the NHS? Would the current left alternatives bring in an NHS? At the moment, there isn't really an indication of that. So I think that in terms of the story, having looked into it and other people's research and research footage on it, what emerges, and as a much easier story to look at, is that all the changes from what was known as the internal market, but can be talked about in different ways as well. And Rathi mentioned that, that it's the legislation from John Major and Margaret Thatcher to date, is that there is a single model, in a sense of, I hate the word model for a medical model, it's really pretentious, but there's an example that's been copied, and that example is how Medicaid and Medicare are provided in the US. Very explicitly, the deliberate reduction away from providing everything to everyone, which was what nationalization, not funding, nationalization made possible, because you could provide everything to everyone, which is what the NHS was, regardless of whether it's profitable or not. And we've been retreating from that throughout all this period, all this legislation, and the stuff that's happened in between the legislation. The policy has served to direct us towards reducing away from what was the National Health Service, providing everything to everyone, and cutting back on all the unprofitable stuff that only the state could do, leaving us with the stuff that the corporates want. So I think that there's a real need to have a discourse, a public discourse that can be addressed directly to the public about those changes, and not to entertain the idea, is it too late to save the NHS? We can't save it or bring it back if we're not talking about it, if it's not on the political agenda, if the political discourse is saying we still have it, but it doesn't have enough funding, and some services are outsourced and sourced, and if we brought them back, it would all be fine. And ignore the fact that the entire thing has been changed to a different purpose, is run on different principles about using US discourse about cost saving that Wes Streeting is coming out with more perhaps than his previous colleagues in both parties, but and using discourse about prevention and so on. But that we have to be able to put, I'm getting lost. We have to be able to put that, yes, into graspable terms what's happened. And it is accurate to say we have copied the US government system for all these decades. It is there. And so, and it's constantly apparent in discourse, where Streeting says he's going to bring in incentives to pay doctors to not refer people to hospitals so much. That's literally the US government system. It's literally the HMO system, and it's not noticed, and it's not picked up by left spokespeople, and that's my big issue. Sorry.
Yes, I was going to say. I mean, it sounds like obviously there's an issue about would left parties bring it back, but I think there's also an issue about the left campaign groups buying into the narrative. And I want to make this maybe a bit more of a round robin section. You know, the left campaign groups are making it, you know, talking about it as if it's about money, talking about it as if it's about, you know, other things than what's actually going on. So, I mean, you two guys know that better than me. So talk between yourselves about it. But, you know, what do the campaign groups need to be doing in order to actually address the issues that are really there?
Well, can I just first of all start by saying, first of all, in addition to what Nico was saying, I mean, we use the word reinstatement, and I think that word needs to be in the conversation more. So, like, the title's really good. Like, is it too late to save the NHS? But as mentioned before, it's not the NHS as we think it is. So we have to talk about reinstatement of the NHS as a fully publicly owned and publicly provided health service. I think that's the first thing. The second thing is actually getting onto the agenda. Like, my experience with the Socialist Health Association is like we're knocking on the door, even if, you know, our closest allies on the left platforms, to try and get this this issue discussed, you know, on the agenda, despite the fact that everyone is talking about the impacts of it. You know, we know about the doctor strikes, about various kind of strikes. We know about the impacts on child health, ageing, all of this. But I am a delegate in conference this year, and we had a fringe last night on exactly this topic. It was the only one. There are, I don't know how many hundreds of fringes, and there are lots of fringes talking about all of the right things, but from the completely wrong perspective, you know.
Yes.
So things, you know, so you'll hear things about prevention, you know, about treatment across the life course. You know, these are all good things, but they're being talked about in the wrong way, not in terms of what's best for patient care. It's all around this, and this word efficiency that keeps coming in. This narrative that well, this is the funding we have. So what's the best way, and, you know, where else are we going to get money? So I've been told this already a few times in the last couple of days. Well, the government doesn't have any money, so we have to go to the private sector. And these narratives aren't being challenged.
I mean,
and yet there are people like Nico and, you know, myself, but many people who have this expertise, yourself as well, who could be given more prominence to challenge this narrative and put it more central in the agenda. I mean, the public does care about it. They just haven't been given all of these facts.
Yes. I think the idea that you can never run something more efficiently when you're taking profit out of it is just mental. But Nico, what do you want to add to that? What do the campaign groups need to do in order to actually highlight the issue meaningfully?
Yeah, I mean, I think my background is in language, and I think I'm very sensitive, probably for various reasons, to somebody coming out with a political narrative that where they're saying things and what they're saying actually implies putting things in a direction that, although the language sounds superficially attractive, it's taking you somewhere where you really wouldn't want to go. And the right is specialized at having stories. That's what they do. They tell you a story that sounds like what you would like to hear. And so what Rathi's describing is a meeting in which the right is using the language of prevention, which, if you want people to be well, you want them to prevent them from getting unwell. So that chimes with your values, but it doesn't mean that. It's a different language. We had a chat earlier, and I'm saying it's like Little Red Riding Hood, and it's kind of like a lot of left discourses at the stage of saying, but Grandma, why are your eyes so big and why are your ears so pointed? And we have to be at a point where we're talking about the wolf
And when any health secretary of the past, however many years, 3 decades probably, is talking about moving health into the community and prevention, those kind of things, what they really mean is closing hospitals and downgrading levels of care.
That's right. They're moving into the corporate community. Sorry, I'm sorry to talk over you. I didn't mean to do that. I just that one thing. They're moving into the profitable bits into the corporate community,
Absolutely.
if you like, if we want to try and reclaim that.
Yes.
Sorry, do go ahead, Rathi.
Rathi, what were you going to say?
Yeah, what was I going to say? Just that the way they use the language is quite pernicious, because if you come from a health background and you hear things like prevention, expanding community care, I mean, from our perspective, that's a good thing. The thing is, what we think they're talking about is different to what they're actually talking about. Do you know what I mean? If you were really going to do expand care in the community, that's actually a very, very expensive thing. And it requires a huge infrastructure, which has been dismantled over decades anyway, and all of social care is gone and all of that. And all of those things could be good. But it is not a cheap replacement for hospital care. Do you see what, and that's how they use it. That's how they use the language. The other thing Nico and I were talking about before as well was multidisciplinary teams. So I'm the generation that kind of, we were kind of brought up on the idea of multidisciplinary teams, and you think, well, that's a good thing. You don't want to be some kind of authoritarian doctor that doesn't listen to, your fellow practitioners from different disciplines, and it's making the care more patient-centred, and that everyone is working together to deliver care for the patient, and that's how we think of multidisciplinary teams. But over time, I've started to realise that when politicians are talking about multidisciplinary teams, they're talking about, well, how can we replace the more expensive staff with cheaper staff? So it's all about substitution with cheaper, less skilled alternatives. And it's not good for patient care. And it's not patient-centred either. That's
one of the things I want to come on to next as well, because people who are watching might not really be aware that, what Nico referred to earlier on as accountable care in the US is already here, and they called it accountable care when they first brought it in. And then the bad publicity around accountable care meant that they changed the name but didn't change the practice. And they now call it integrated care. But integrated care is essentially about rationing. It's about closing hospitals. It's about incentivizing healthcare providers not to provide care. And they get a share in the savings. Wes Streeting, since he became the health secretary, is now offering doctors cash to not refer people to hospital. Which has got to be a perverse incentive. So, I mean, I'll bring you in first on that, Nico, but, this whole thing, how does that fit in? And then when Rathi mentioned this substitution, or some people call it downskilling, we're actually, the NHS is accelerating its replacement of actual doctors with people who aren't actual doctors and not telling people the difference. So give us a little bit, both of you, on that. Nico, you come in first.
Yeah, I mean, these are aspects of the reduction to getting rid of the unprofitable stuff. There's of getting rid of the whole that was the health service, that was making sure everybody had all the care they need, had everything from a general practice to a general hospital on their doorstep. That was the basis for what we had, and that is being taken away. And it's not a funding issue. It's wanting to take away the care because somebody benefits from that care being taken away issue. It's a privatization issue, and it's understanding privatization as government policy in the same way as in any other area but health. It's exactly the same way, and looking at who is in charge of that policy, where it comes from, and noticing that the same corporations. I mean, every doctor came out with a report recently that pointed out corporations that were getting involved in the current 10-year chapter of cuts and privatization, Wes Streeting is associated with, and mentioned a figure who he's United Health's director of strategy. Didn't mention, but this is the point. I'm talking, it's a bit kind of crossover perhaps with other questions in that you're covering, but we have a left alternative, and we have examples here, living examples of how this figure, for example, is head of strategy for United Health, was previously head of strategy for this thing called NHS England under the Tory government, and before that was Tony Blair's chief advisor on health. And this is not an exception. This is the rule. This is the way it all works.
You mentioned United Health on that, and
yes.
I mean, recently the United Health CEO in the US, who I think is a Brit, made a video for people in his organisation reminding them that their job was to stop people getting too much care. He said sustainable care, but it's still the same thing. They don't want to, they make their money by not treating people. Rathi, what's been your kind of experience of this and how do you see it?
Well, one thing that's also important to say about accountable care organisations is that there has been research done. People do look at the impacts on patient outcomes, and actually, and actually one other thing to say as well is, although it's billed as this cost-saving thing, there's huge startup costs to it in the first place. But then on top of that, patient outcomes are poorer, and a huge part of that is lack of continuity of care. I mean, all the way across this thing, it's all about the fragmentation of care, because it's about, well, what can we make money off rather than how do we provide care for people and patients. So we have lack of continuity of care, reduced access, so access is harder, and particularly for people in the poorest communities, access is harder. They probably find they have to go further, or it's not available in their local area. Some of this research comes out of America as well, where they have decades of experience of this. Poor coordination of care, because if you had a one joined up system, fully publicly provided, of course your system is joined up, and referral, of course, everyone has their stories about when it didn't go well, but it's all in the one service essentially. Here it's in this under the same logo, but it's not in the same service. They're all different providers who've got nothing to do with each other. So I'm actually also a carer myself. I have carer for 2 disabled elderly adults, and I coordinate the care. You know what I mean? No one in health service is really doing that anymore. So there's certainly poor coordination of care as well as the fragmentation. And then what they've seen in research as well is widening inequality, and the performance. So the poor patient outcomes is particularly impacted by the social determinants of health. So in the areas with the highest socioeconomic deprivation, the poorest areas, you see the worst patient outcomes under these systems. So the people who need the care the most are actually the worst off in a system like this. And that is the opposite of the principle of the NHS, right?
And one of the ways that this is most working out at the moment, and maybe getting, or should have headlines, it's not getting too much, is the fact that, that people on the ground will moan, I can't get to see a doctor. But when they get to see a doctor, whether that's in hospital or in a GP's practice, they're often not seeing a doctor when they think they are. So the government calls this, in some cases they call it practitioners, usually they're calling it associate, so associate, physician associate or anaesthetist associate. I remember with horror hearing a former Tory health secretary say about how fantastic it was that someday we'll have one qualified anaesthetist managing several
supervising,
semi-qualified anaesthetists online while they actually anaesthetize people, and what could possibly go wrong. Last week we had a child die from sepsis after being misdiagnosed by an unqualified associate or practitioner. There's been a couple of notorious cases of people being diagnosed with the pulled muscle or whatever, and then all of a sudden they drop dead from a thrombosis or something. So the government knows, that's the other thing, the government knows that it's dangerous because they've done their own research on it, and they concluded that there is no scenario in which replacing actual doctors with people trained to a particular task or something is not dangerous for patients, and yet they're still doing it. So what's going on with that? Why is the government deliberately making choices that they know is going to kill people?
Well, I think because it's cheaper.
No one's challenging them. Sorry, go in.
Yeah, go for it. It's
not on the political scene. Nobody's challenging them, and I will caveat that a bit. I will say, for example, in the Green Party, you have Natalie Bennett, who has challenged that in the House of Lords, but the Greens, which I've joined, by the way, and I've had to leave the Social Health Association because of that. But the Greens I'm not going to say it's the ideal. There isn't one. I joined Labour in 2011 because it was so bad and it needed changing, and that's enough for that for now.
While you're on that, it's worth mentioning that Natalie Bennett, when that was in the House of Lords, she tried to kill the plan to expand the use of these associate roles, and Labour, which was in opposition at the time, sided with the Tories.
Of course,
that helped defeat her bill. So those are the people now running the country. Yeah.
They've supported that throughout their time in opposition, even when Corbyn was leader, because except when he had Diane Abbott in, who did oppose this very briefly, in language that wasn't so easy to understand it wasn't broadcast, let's say. John Ashworth, Heidi Alexander were completely in support of all these policy changes, all of them throughout, and they spoke on behalf of the Labour Party, even while Corbyn was leader, sadly. So that is another big reason we need a different narrative than the sort of narrative that's sort of come out from that, because that is not an opposition narrative. So, and Natalie Bennett, I was saying, we're saying yes, has opposed this, but it's invisible in Green Party discourse at the moment. It's not there. It doesn't exist. And got
very little coverage in the media as well. I mean, Rathi.
That's as a result, because there are people like Zach Polanski. He's just been elected. He has a radical position. Let's say his position on the left. But we on health, we don't have. And we had Corbyn for 5 years, but we and more, because he still has some kind of voice, even if it's marginalised. So it's not been in the mainstream. It's not been said. Saying it to me, in the opportunities that we have to say it, that we have government policy that is about reducing away from, is about taking away the services we need on behalf of corporations, and specifically talking about how, including on the replacement of doctors, is central to what's happening, and the only way politically to be able to do anything about it is with a public mobilization of the public. And the closest thing we've come to that is David Cameron's faking it in response to New Labour, and it's really worth looking at that, because he did everything but actually oppose, but he vocally he basically co-opted the anger against mostly hospital closures at the time, and also GP closures in favour of polyclinics, and basically business models replacing actual services that people could receive.
There's one more thing I'm aware we're running out of time, and there's one more thing I want to cover before we do. But is there anything you want to add to that, Rathi, before we move on to the next bit?
Just on what we should do on PAs, and it is wider than just PAs in terms of the substitution. But I think this is an issue that could because patients, when they know about it, they don't like it. It's getting reported on mainstream news, so more and more people are hearing about it. The health profession also does not like it. So the doctors themselves are very active on this policy. I mean, they're facing like 20,000 resident doctors facing unemployment. It's impacting their training. So I think it's an issue that can unite a much broader coalition around this issue as a lever to kind of pressure on the underlying issue, like why is de-skilling happened? It's not just a random thing. It's part of this whole, like make things as profitable as possible, expand your profit margin. If you're going to have a GP surgery, it's much better if you have cheaper employees and less doctors. So I think that's what we should be doing, is that we should be working together, mainstreaming this message. We actually, with KOMP, we have a postcard on our website that we distribute to ordinary people to say, give this to your GP surgery, to say, I want to be seen by a medically qualified doctor, or to your hospital clinics. You fill it in, you hand it in. When I speak to people on the street, this is something that they either know about and they're like, yes, please, I want one, or there's there are people who, when you explain about it, they're horrified. You know what I mean? Yes. Ordinary people understand that they want to be seen by a medically qualified doctor. That is their right. So I think this is really something that we could mainstream and use it, as I say, as a gateway into to opening up this debate.
Yes.
To understand the whole kind of the cost cutting and the privatisation and all of it. Really.
It reminds me of a scene in Scrubs where the janitor puts a white coat on and goes around and starts treating people. It was funny in that, but it's not funny when
it's not funny when it's real.
People are getting sick because of it.
Yeah.
So this might be the last section we get a chance to talk about. So we'll have to be quite brief. But I'm going to play devil's advocate for a second. Wes Streeting says the NHS must reform or die, but they've only been in government for a year, only feels much, much longer. But they claim that they've got an ambitious 10-year plan for the NHS. Is that a good thing?
I mean, the NHS needs to reform in terms of it needs to reinstate a publicly provided NHS. That is the line. In terms of his 10-year plan, there's no reform. It's just more of the same. The 3 shifts he talks about from treatment to prevention, from hospital to community, we've talked about already, and it should never be an either or, right? So that's the thing. Well, all of those things are important. Prevention is important, but not the way they're talking about prevention. The amount of lives you're going to save with things like expanding newborn screening is minuscule compared to the amount of lives you could save with a proper, multi-sector approach to improving the health of the public, poverty reduction, improving housing, all of that. That is really what's needed in terms of prevention, and that would make a massive difference. They don't understand prevention, so that what they understand is what can we make money off? What do companies want to do?
I think it's how could we blame people for their own ill health?
Well, absolutely. That's the other point. And I was in that prevention fringe meeting yesterday. That was the other thing. So they picked out some groups that they talked about. They picked out disabled, a BAME, which is an outdated term, and I would add obviously the poorest communities to that as well. And they said, well, they're not accessing the health prevention and health promotion strategies that we're pushing, like more walking and so on. So they seem to think, well, if we just tell people to stop smoking and go for more walks, then they'll be fine.
And
which
in some
is
cases
not
make them take weight loss drugs, which we've seen with West Street in partnering up with the DWP to say if you're out of work and we think you're fat, then you could lose your benefits if you don't take this. Quite dangerous.
It's very, very, very dangerous. Very shocking for a government to be doing something like that. Yes. It is not his job to tell anyone to take any kind of medicine. If he wants to do that, he needs to go to medical school first. So I just think it's just continuing what the Tories did, which is always vilify people, you know what I mean, and make them blame them for the conditions they find themselves in. Poverty is intractable. We have huge power as a country, because we are such a rich country, to be able to alleviate all of that and have a healthy population, which will lead to a healthy workforce. Yes. That is what prevention should be all about. And you need to understand the communities and work with them, not just tell them to stop doing things that are unhealthy for them. And this is actually true for us as practitioners as well, because I was always trained, you need to give people nutritional advice. Do you think that mothers who are feeding their children, chip bombs or, these kind of unhealthy meals, do you think they don't know that they'd be better off feeding them vegetables and proper protein sources? Yes. Of course they know, but they can't access them. Do you know what I mean?
Yeah,
so I think the prevention argument is just wrong. The community, as we said, should not be. It's not. It's not a replacement for hospital care. And then the other one from analog to digital, the doctor in your pocket. So what I would say with that is there are important technologies evolving all the time, and they are best used and innovated by the specialists in the services, and like the doctors and other specialists.
Not by US spy firms, which is who they've given the data management contract to. Nico, I want to get a couple of minutes just from you, because if you're still there.
Yep.
Surely Wes Streeting has put the best possible people in charge of his 10-year plan to implement it and make sure that it's going to be good for everybody.
Yeah, it's just the same people as have been for the last few decades. It's people who we've written about it at the SHA about walk through a corporate revolving door to and from the big US transnationals in particular, and other health interests, private health interests as a rule. So it's the same people with the same policies and pretty much the same narrative. And so it's really a huge open goal for the left in that sense. If there is a will to confront corporate control of health policy, that is corporate control of an entire sector, not just little bits of outsourced bits that we've got to focus on, but control from the top, then it's a totally open goal, and there's plenty of material to use or to keep ignoring, which is what's being happening.
I've just found out we've got a bit longer than what I thought we had, because we've managed to carve out a little bit longer for the discussion. So, let's talk in a bit more detail about that then, and I presume you're both aware of this, but the people that they actually put, he's basing his 10-year plan on the Darzi report, and Darzi is somebody who has praised Margaret Thatcher's kind of health reforms, praised the other Tory health reforms, and the kind of implementation lead on this, as I understand it, is a former McKinsey partner. And he's running the thing on behalf of the government, and yet he used to be a partner in one of the biggest health privatisers in the world. So, how's that all working out? How's what are they planning to do to people, and how's that going to hit people on the ground when they're trying to get into A&E, or they need to get a hospital operation or an appointment with their GP?
Okay, sorry, Rathi, shall I go?
No, you carry on.
My bit?
Yeah, no, I'll go after you.
I understood it had been my bit, that's why.
Sorry.
Okay, is that okay?
Yeah, no, continue.
Go for it. Go for it, Nico. We'll bring Rathi in after that.
I'm going for it. So, we've named a couple of, pointed out a couple of individuals, but I'm not sure about the McKinsey guy, what his final role was in it. I'll just admit I haven't followed exactly. I know that one of his people who used to work for the IPPO when he ran it is claiming authorship. I just haven't followed that closely, and I'll say it doesn't make a big difference. What would make a big difference, what would be an exception, would be somebody actually defending public service, and that's what we don't have, because we have an institutionalized commitment to principles that are about business first, and ever since the head of Sainsbury's were brought in to make changes to the health service in the Thatcher years, that's been the direction. So the thing about it is, what will people have to come to expect from it? Well, less of the wholesale service that we used to have, just continually less of that and more gimmicks. So some of those gimmicks may help at some point for some things, but they're not the full service. And I think, so I'm just going back to the previous thing you were asking, but when they talk about more prevention, it's just in terms of how we talk about it, it's less provision. And when they talk about more services in the community, shift more services in the community, it just means less hospital care. And it's about how you present the destruction of a service as a well-meaning changes based on changing social needs, are supposedly driven by an aging population, blah, blah, blah. Sounds really boring, can't possibly be threatening, but it is, because what it really is of the wolf dressed as a grandma. So that's what the discourse is, but it's the continual cutting away of the unprofitable stuff that we really need, and the need actually politically to define the sort of Thatcherite corporate figures opposite us, because they don't define themselves that way to the public. Yeah. And when you talk about the profitable stuff, you mean things like hip replacements that can just be done over and over again on a production line, that kind of stuff. That'll be the profitable stuff, minor injuries and so on. But the unprofitable stuff I was talking about is what's being cut away, such as having access to a doctor as a first port of call, or having a local A&E you can get to when you need it, or those things are not profitable, and they're being got rid of because of that. And people who work in it have the story framed to them in such a way that they many ways sound completely convinced, or at least partially convinced, that what they're doing is well-intentioned, and they have a discourse. And even people participating in a crime like genocide will have a discourse that justifies it to them, because there's varying levels of participation in this, and a lot of people who are well-intentioned have only heard the official version of what they're involved in, and they don't have anything else. And that's the left's job to tell them, no, this is about getting rid of unprofitable services, and not leave the PA stuff, the replacement of doctors, to a marginal thing that you mentioned sometimes on a postcard perhaps, but it's central to the dismantling of the service. It's the wholesale changing from above.
Yes. I mean, there are papers where NHS people, management people, talk about this quite honestly, and say that it is about increasing profits, and it is about cutting costs and rationing services and so on. But are the foxes in charge of the chicken coop?
Oh yes, very definitely. But just to go back to the Darzi report, I think the Darzi report for me is a little bit of a distraction because there was a lot of fanfare around it. It didn't actually tell us anything we didn't know already, but it's kind of been used as almost to provide evidence for whatever the government wants to do next. And actually what we do need is a really honest report that looks at all the stuff that we've been talking about now, the funding and structure, and how does that impact the health, where is the money going? They talk about it, when we talk about money, we should talk about how much of the money is actually being wasted, out into the private service when it could be used in a more effective and efficient way. And so in terms of things like Darzi and the 10-year report and the implication for, like you said, people going to the emergency service, because so many emergency services have been closed, this is really life-threatening now. People are waiting long times to get an ambulance, let alone get in the door of the A&E once they're in the ambulance, because the ambulances are all queuing up outside. And I've had this experience myself with my mother, but queuing up outside the A&E to even get in, to offload the patient they have to go and get the next patient. And that's not happening because I mean, you can talk about population aging and all the demographic changes and whatever, but the reason is, I mean, I've been sitting with ordinary members of the public sitting nearby who've said exactly the same thing because they recognise it in their community. It's because they closed that hospital A&E over there and that hospital A&E over there. So now this much bigger catchment area is all on the one A&E, which hasn't changed.
Yes.
So that's why that's happening. Maternity services, another thing, essential care. That is not tertiary care. It's not optional. It's essential care. It should be delivered in your locality to a high standard and according to evidence. And instead what we're finding is it's becoming more of a tertiary service because it's moving so far away from people. Why are they closing these units? It's quite expensive, maternity care, and there's a lot of insurance involved and things that make the cost very high. So it's not a very profitable service to run. So these are the things that are life and death that we are losing, and of course, hip replacements, cataracts and all those things are really important. But don't believe we're streeting when he says that we need the private sector to help us deliver it, because actually we would deliver it a lot better and a lot cheaper if we could bring it all back into in-house, into NHS. Don't forget there's only one workforce. We only have one NHS workforce. So if they have to spend half the time servicing the people being treated in the private sector, the people on the NHS waiting list are waiting longer. And those two groups of people are not the same. So these people tend to be poorer and sicker than the people who more often end up on the private provider list. So even though you're not paying at the point of access, that you're seeing that widening of health inequality, and you're seeing a knock-on effect on the core services. So in ophthalmology now, you're seeing ophthalmology services being told, well, you're not doing enough surgeries because they've lost all the cataract surgeries to the private providers. They're now being told, well, it's not viable to keep you open anymore. But they're the ones providing the life-saving and sight-saving treatments, like for some cancers, for retinopathy of prematurity, for preterm babies. Private providers are never going to pick that up.
Yes.
So all we can see at the moment is no end in sight and no reversal of all of these kind of really dire things that are happening, unless, as we say, we make a definitive call for reinstatement of a publicly provided NHS, bring it all back in-house.
We're in the last 2 minutes now, and I apologise, Nico, because I was going to give you the last word, but there is one more thing we need to cover, because yesterday we saw the Starmeroids get a bit of a bloody nose from the Palestine motion that was successfully passed in the conference. You've got a health motion at the conference this year. Can you quickly tell us about that?
No, we actually, our health motion always gets sidelined, to be honest. So we put an emergency motion on Gaza, so we were part of that compositing, and very grateful to be part of that group and to see that go through. And it does show what we can do when we all unite and work together, even in these times. We shouldn't forget that hasn't stopped the genocide. That's just one step. And now everybody needs to hold the government to account. That's what the members decided. The membership decided that, that we recognise that this is a genocide. We need to hear that from the leader of this government now, and that we will stop all arms trade with Israel, and that needs to happen. We need to start saving lives now. We've facilitated a genocide for far too long.
Last 30 seconds then to you, Nico. Very quickly, what do we need to do if we want to restore the NHS? Let's say not save it, but reinstate it.
Well, talk about how it's been uninstated. Talk about that as the key centre of political messaging on the service when you're offering wanting to offer an alternative. And if you don't know what that means, find out for yourself. But you have to be able to bring that into public debate. Otherwise, it's never gonna happen.
Very good.
You need to get a grip on it.
Thank you ever so much, folks. We'll encourage everybody who's watching now or on clips later to follow both of you on your social media presences, wherever those are, and keep up to date with what's going on, and to roll up your sleeves and dive in, because the NHS is already on its last legs and fast disappearing, and may get to the point where there's no realistic prospect of restoring it at all. So I do thank everybody. Again, I'll just point everyone to the donations link if you would like to support us. Is yourshow.uk/donate. Thank you very much, and we'll see you very soon when the next session begins.